Hello again, everybody. This is going to be a talk on epiglottitis. Epiglottitis is used to be a very common problem, particularly in emergency departments and among pediatric practitioners. It is not so much a problem anymore. Nevertheless, the USMLE really likes to test you on this because it's got a very typical presentation in most cases, and there are various radiographs that you can read that they want to know, that you can see the signs, and so for the most part, you're not going to run into this very often, but I do want to address it because the test does test on it. Okay, so we are talking about various acquired upper airway diseases in children, and epiglottitis is one of them. Apart from foreign body obstruction in some cases, epiglottitis is really the one that is the most deadly out of all of these. And so if a child has epiglottitis and does not get treated, or is not treated effectively, they will die. So the urban legend is that George Washington, the first president of the United States, died in 1799 from epiglottitis, but we don't know that for sure. However, epiglottitis is typically caused by a bacteria called H. influenza type B, Haemophilus influenza type B, and this is declining in prevalence. And the reason is because we vaccinate children as part of their standard routine vaccination care. We vaccinate them against H. influenza type B. And so it's not as common anymore when a patient comes in with epiglottitis that it's epiglottitis caused from H. influenza type B. And there are other bacteria that can cause epiglottitis. However, Haemophilus influenza type B remains the most common cause of epiglottitis. But definitely in a patient's history, look for when did they get their HIB vaccine. And if they didn't get it, then that's a clear indicator that they were at risk for epiglottitis from the get-go. All right, so start out, what is the epiglottis? We don't see the epiglottis. It's not something we see very often unless you're frequently doing placing oropharyngeal tubes or you work in that specific part of the body. So what does the epiglottis do? It is just a flap. It's made out of elastic cartilage. It's relatively thin, and it has an overlying mucous membrane. It's attached to the top of the larynx at the anterior thyroid cartilage, and it projects upward from its base at the anterior thyroid cartilage behind the hyoid bone and the tongue, and it points dorsally at its superior end. So it's going to point backwards. While you're breathing, it's going to lie entirely in the larynx, and that's good because if it weren't laying in the larynx, where else would it be? It would be in the oropharynx, and you don't want that to happen because if it's above the larynx somewhere, not laying up flat against the wall of the larynx, then you're going to be impeding breathing. So you want it flat and not getting in the way during breathing. Now during swallowing, it serves a different purpose. During swallowing, it serves to actually block something, and what it's blocking is food. It's blocking food from getting into the trachea. And so we don't want to aspirate what we eat or drink, and the epiglottis helps us do that. So during swallowing, it assumes more of a horizontal position, and that allows it to protect the trachea from whatever is going to be going down into the esophagus. I'll show you some pictures of that on the next slide. Epiglottitis is a pediatric medical surgical emergency, and this is acute inflammation in the supraglottic region of the oropharynx, which primarily includes the epiglottis, the vallecula, which are these two little tiny ridges behind the tongue that hold saliva, the arytenoids, which is a type of cartilage, and the aryepiglottic folds. So these are all supraglottal structures above the vocal cords. So here's a good picture for you here. So this would basically be like if we took the tongue out and the trachea got dragged with it. This is what we're looking at here. So here's the tongue, and then here's the epiglottis. Now typically you can't see your epiglottis very easily. You can see your tonsils and you can see your uvula, but the epiglottis is down a little bit further. Here's those vallecula that I was talking about, and the epiglottis is down here. Now the epiglottis sort of serves as this kind of dome-ish like structure over the proximal part of the trachea, right around where the vocal folds are. And if you keep going distally, you'll see the glottis, the vocal cords here. And then you'll also see the arytenoid cartilage and the cricoid cartilage. And you're probably wondering where the thyroid cartilage is. The thyroid cartilage has been removed, so you can see the epiglottis, because the epiglottis is behind the thyroid cartilage. So the thyroid cartilage has been dissected here. And so now you can see your vocal folds, vocal cords, and then you can also see the epiglottis. Now, when you are swallowing, well, let's say when you're breathing, and this is the trachea here, you can't see the esophagus, but when you are breathing, you want that epiglottis to be nice and flat up against the wall, and so it's not impeding anything into the trachea. So you breathe, you don't want your epiglottis to get in the way. So if you were in this configuration, it'd be a lot more difficult to get air in. So you get your air in like this. This is the breathing configuration. Now, when you swallow, the hyoid is elevated by the digastrix. This is the hyoid muscle here, or hyoid bone here, elevated by the digastrix, as well as the stylohyoid muscles. And the vocal cords also adduct by contraction of the lateral cricoarytenoids, as well as the oblique transverse arytenoids, all of which are innervated by the vagus nerve. And what this allows to do is it pulls on the epiglottis, it pulls it into this horizontal configuration. So now the epiglottis is covering, protecting the trachea. And so when food comes down, it's not going to go into the trachea, it's going to go down through the esophagus. So here's another example. So here's your trachea here, here's your esophagus here. This is just a cartoon. So you're breathing, you got your epiglottis nice up against the this anterior sort of wall of the larynx, and the air will go straight down through the windpipe into the trachea and so forth. When you're swallowing, the epiglottis gets pulled down to this horizontal position and it covers up the trachea. And by covering up the trachea, then you can swallow, and this is all part of your swallowing or your deglutition reflex. And it covers up the trachea and allows for the bolus of food or water or whatever to go through the esophagus, and more importantly, not into the trachea. So this is an epiglottis here. This is a healthy epiglottis. Epiglottises can come in different shapes. However, this is probably the more common sort of shape that you'll see. And so you see down here, you got the vocal cords down in this area. These are your arytenoid cartilages here. And then this, pointing to the blue, is your epiglottis. The epiglottis tends to be a little bit paler than the surrounding tissues. And you also will see some capillaries on it as well, and that's normal. Here's another view. This is looking through the patient's mouth. So this was done by like a fiber optic nasopharyngeogram. This, you're just looking into the patient's mouth. In this patient, you can see part of the epiglottis here. And this is a healthy looking epiglottis. I'm not sure what else is going on in this patient's mouth, but this is a healthy appearing epiglottis. It's the right color. It's sort of a peachish color. It should not be red. It should not have pus or bleeding on it or anything like that. It should be this nice sort of off orange color. So here's just an anatomic idea as to where the epiglottis is, and this is going to help you when you look at x-rays to see if the patient has epiglottitis or not. So here you've got your mouth, your tongue, your nasal passages converging onto the nasopharynx, or the oropharynx, nasopharynx up here, oropharynx, and then now you're in the pharynx, and this is your epiglottis. And note that the epiglottis is directly posterior to the hyoid bone. Hyoid bone, if you're getting a good neck radiograph, a lateral neck radiograph, the hyoid bone is very easy to find. All right, so it's right, because it sits right about, maybe a little bit posterior, but right about where the chin ends and the neck starts. So that's the hyoid bone, and then you'll look for this little, usually it looks just like almost like a leaf, like a leaflet coming in, and it's very thin. And that's the epiglottis. And remember the configurations they take. This is the configuration you would be in when you're breathing. So you get air down into your trachea, but when you're swallowing, this is going to come down to the horizontal position and cover up the trachea. Okay. So then when you look laryngoscopically, when you're looking at the vocal cords, look at the glottis, you have your vocal cords here, and then through that, then it becomes trachea. The epiglottis is going to be more on your anterior end here, and then your arytenoid cartilages are down here. And then, so hopefully that settles that. If you have any questions, let me know. I don't want to get too in depth into the anatomy here. So what causes epiglottitis? We already talked about that. Haemophilus influenza type B is number one. It's 25% and declining. And the reason it's declining is because people are getting vaccinated against influenza type B. And so it's less and less and less now. But there are other organisms that can cause epiglottitis. One would be Haemophilus parainfluenzae, which we also see is a cause of croup. Streptococcus pneumoniae, group A strep, and then there are some other ones that are much less common, group C strep, Neisseria meningitidis, Pseudomonas, Moraxella catarrhalis, Klebsiella, Pasteurella, and Candida albicans. That's typically going to happen in HIV/AIDS patients. There are also some non-infectious causes of epiglottitis. So if you were to ingest a very hot coffee or a hot water, that can irritate the epiglottis to the point where it swells and then can cause epiglottitis. Even more so, caustic substances like bleach, if you were to swallow that, that can irritate the epiglottis and cause it to swell. And then things such as trauma, post-foreign body ejection, and chemotherapy to the head and neck can also enlarge the epiglottis. But for our purposes, we're really talking about these causative organisms, which are primarily bacteria. Having a previous viral infection can predispose you to a bacterial superinfection. So remember that things like croup and laryngitis, those are viral infections. Having something like that can predispose you to a superinfection with a bacteria, and that can cause epiglottitis. So look for that in the patient's history. So like I said, this was formerly common in the US, now it's rare thanks to the HIV vaccine. Its incidence is about 1 in every 180,000 people, 0.63 per 100,000. Particularly epiglottitis occurs at the age range of 2 through 6 years old, so sort of that preschool, early kindergarten age range. The history with epiglottitis is that it has a notoriously abrupt onset of symptoms. Typically there's no prodromal symptoms, but like I mentioned, the patient may have a history of a recent viral infection, but that's a completely separate illness. Usually that infection will subside and epiglottitis comes later. Fever is going to be the first symptom. So these patients will develop a fever. They won't want to eat. Why do they not want to eat? Well, they have dysphagia. Why do they have dysphagia? Because remember, the epiglottis makes up part of the anterior pharynx when you're swallowing. And so you brush up food against the that swollen epiglottis, and it's painful. And so the patient may say, I have a sore throat, or when I eat, it's uncomfortable. So they'll have either dysphagia, or if they're a baby and they can't tell you that, it may just be a refusal to nurse or a refusal to eat, anything that involves swallowing. Due to the inflammation, they can also have this muffled or hoarse voice. They call it a hot potato voice. Basically what it sounds like is if you kind of have your mouth full of hot food and you're trying to talk like that, it's sort of muffled and the consonants don't come out correctly. And that makes sense because a lot of our letters that we use in language actually involve the epiglottis. And so if that's not functioning properly, our accent is going to come out really strange. We're not going to be able to talk correctly. And then, like I said, sore throat. That's again just due to the soreness of the epiglottis. And if you have enough respiratory distress, you can get anxiety from that. And then another thing that I put it on the physical here. Okay, so when the patient comes in with those symptoms, particularly fever, would be sort of the first thing that happens. Patient could appear toxic. Shock can appear early. This is often, if it's not treated, very rapidly progressing disorder. The patient may be in what's known as the sniffing position. What that is they're simply leaning forward with their chin hyperextended, their neck hyperextended. And it kind of looks like if you were to lean in any more, you'd be sniffing a flower. A lot of times they'll keep their mouths open with a protruding tongue. Why? Because that's pulling the epiglottis into the position that you would want to pull it into if you were breathing. But unfortunately, because it's swollen, it is now obstructing the windpipe. It's obstructing the larynx, the trachea, and so that's why they have difficulty breathing, and that's why they put themselves into that position. They learn a position that helps them breathe. That's leaning forward and hyperextending the chin. They're just manipulating the epiglottis to allow for more air entrance into the trachea. Because the epiglottis can also cover up your swallowing, or the patients may not swallow because it hurts, you can get drooling. Then, of course, also you get stridor because of the air turbulence going in and out of the lungs. Once you get into respiratory distress, you see things such as accessory muscle use, and then cyanosis after respiratory, once you get respiratory fatigue. Because this is infectious, it's bacterial, you can get tender lymphadenopathy in some cases. And that, of course, will be around the neck. Okay, let's go back here. So this is an example of that sniffing position. So note that her mouth is open. She's also got her hands on the floor. That also helps her with breathing. This is called the tripod position. But she's in that sniffing position where her chin is hyperextended and she's sort of leaning in here. Here's another example. Mouth open, leaning in, chin hyperextended compared to the neck here. And here's another kid that's totally like that again. Mouth open, head sort of pointed upward, he's got his chin hyperextended, and he's leaning forward. These are all children with epiglottitis. So how do you approach epiglottitis? So the first question is this patient stable? Is this patient stable particularly in their breathing? And if the patient is in respiratory distress, and by respiratory distress, what I really mean is that they can't maintain a saturation of oxygen above 92, they are not breathing on their own, if they're using accessory muscles of respiration, if there's nasal flaring, if they're in any of those advantageous positions, or if there's any abnormality with their Glasgow Coma Scale, if they're less alert, at that point you're going to go straight in for the airway. Only the most stable patients can we wait and see while we're working them up. So if there's any signs of respiratory distress, these patients are going to be immediately wheeled off to an OR where they'll get halothane anesthesia and an insertion of an orotracheal tube. Now, let's say you have a stable patient and you haven't had to do that yet. You still want to avoid procedures until the airway is secure. So the reason is that you don't want the child to get excited and need more air, because if they get upset, they're going to start crying and they'll need more air, and they may not be able to get that air in, and then that can cause respiratory distress, and then you have to trach them or stick an orotracheal tube in them or trach them, depending on what works. So you want to try to avoid any stressful procedures until the airway is secure. So don't be getting labs while you're preparing an unstable patient for mechanical intubation. That's just what I wanted to get out of that. All right, and the labs you want to get, once you have secured an airway, you want to get a basic metabolic profile, you want to get a CBC, and then you also want to get cultures, blood cultures. If the diagnosis is questionable, meaning this patient doesn't necessarily show all the signs of epiglottitis, maybe they're breathing fine, they got a little bit of adenopathy in their neck, but they don't have a fever, then if the diagnosis is questionable, you can get a portable x-ray. You don't want to send a child off to an off-unit radiology. You should perform this at bedside. And I didn't put it on here, but you should be getting a lateral neck x-ray. And when you look at that neck x-ray, you should see if the patient has epiglottitis, you'll see a thumb sign, and I'll show you what that looks like. Otherwise, if the diagnosis is presumptive for epiglottitis, what you're going to do then is you're going to do nasopharyngoscopy or laryngoscopy, which can confirm the diagnosis, as you can obtain cultures of the epiglottis through this procedure. And this procedure has superseded the x-ray as the preferred method of diagnosis. Nevertheless, the USMLE will want you to know what an x-ray with epiglottitis looks like, and that's why I'm going to show you some pictures. Once the diagnosis, this is important too, especially if you're taking step 3, when the diagnosis of epiglottitis is made, even patients who weren't in respiratory distress when they presented, and maybe even aren't in respiratory distress now, they still need to be intubated. So you're going to intubate all patients with epiglottitis, regardless of their clinical. Once you've diagnosed them with epiglottitis, boom, time to intubate them. That's the way it is. And there was a study out that showed that less than 1% of children who are intubated, less than 1% of children who were intubated in the hospital died, whereas children who were not intubated in the hospital, about 6 to 10% of them died. So for this purpose, we intubate everybody with epiglottitis. The only difference is patients who present with respiratory distress and related symptoms, we are going to intubate them immediately. So this is a normal epiglottis. So we're looking down from the tongue here. This is your uvula, and here is your epiglottis. Okay, so now we're looking at the epiglottis downwards over the larynx. Again, it's normal. It's a little bit lighter than the surrounding tissues. You see some capillaries on it, but this is a nice looking epiglottis. Okay, so this is epiglottitis. So epiglottitis, notice the swelling. So notice how you have the sort of U shape, and when they're swelling, it sort of forms more of like this, well, it's sort of like a very swollen U shape. Note that there's erythema around along the mucous membrane of the epiglottis, and that it's a lot bigger. And so you can see that when this is over the trachea, just like this is over the trachea, when this is over the trachea, you only have this amount of space to breathe through. And so the resistance is going to be much, much, much higher. Here's another example. I'm not sure the exact perspective here, but again, this is an epiglottis that is swollen. So here's an even better example. This is just a cartoon, but this is showing you on the left a normal esophagus, a normal epiglottis. So that's right here. Remember I told you, look for the hyoid bone, then go straight behind it, and you'll find your epiglottis. So here's your normal epiglottis, right here, this structure. And this is an epiglottis with epiglottitis. So you note the swollenness all along the epiglottal structure. So here's an X-ray showing you a normal epiglottis. So note that again, here's your hyoid bone, right? And this is the epiglottis. So the epiglottis is very, very thin. Okay, usually it's half the size of your pinky, maybe like the size of a pencil in shape. So it's very small, very thin and long. You can see the difference here. Now this is a little bit lower resolution, but you can see how this epiglottis is quite thin. This epiglottis is quite clearly enlarged, and this is epiglottitis. We'll look at a few more pictures. Okay, so here's your hyoid bone, and then right behind that is your epiglottis, and you can see that this is not a nice thin little flap, but indeed it is a bulging, swollen epiglottis right here. So if it's the size you can place your thumb on it, if it's got roughly that kind of morphology, then it's probably epiglottitis. But if you go back here to the normal epiglottis, that doesn't look like your thumb at all. Okay, whereas something more like this does look like your thumb here. I got another picture. Okay, again, this is even better. So a hyoid bone, go back, here's your epiglottis, and you note that, again, this is not a nice linear flap. This is a congested epiglottis, and it's roughly the shape of a thumb rather than a flap. Okay, and then here's another one. So this is your swollen epiglottis here. So hopefully you've got an idea of that. For the most part, your vignette should make it pretty clear that the patient has epiglottitis. If you just think of stridor, drooling, assuming that the sniff position, maybe their saturation levels are low, they have a fever, it came on suddenly, that will, for the most part, give away your answer. And then you look at a neck x-ray, just look for the epiglottis. If it looks like a swollen sort of thumb appearance, then it's a swollen epiglottis. If it looks like a nice flap appearance like we saw here, that looks nothing like those. This is a normal epiglottis, so then it wouldn't be epiglottitis. All right. So what do we do for treatment for epiglottitis once we have admitted the patient with a diagnosis? So we're going to admit them. Usually we admit them to the ICU because they are at risk for respiratory distress. So you can consult ENT, anesthesiology, or surgery as necessary. These patients will also be followed up on by a pediatric intensivist for most of their care. You want to avoid putting them into the supine position because that can precipitate respiratory arrest. You also want to keep an emergency cart by bedside. Make sure that you've got all your tools in there necessary for intubation. IV antibiotics are the cornerstone of therapy. They work very quickly. You can use a third or fourth generation cephalosporin, which has tremendous coverage over those a lot of those gram negatives and some of the gram positives that are most involved in epiglottitis. So a third or fourth generation cephalosporin. The thirds include ceftriaxone and cefotaxime. The fourth is cefpurixine. And then you're getting your cultures back from your blood testing. So as usual, if you need to, you can change the antibiotic according to culture results. As far as their nutrition, it's going to be nil oral because they're intubated, so you put them on D5 1/2 normal saline to meet their glucose needs. Extubation can often be performed about 24 to 48 hours after intubation, provided that there are signs of resolution. So looking at the epiglottis, there should be decreased erythema and edema of the epiglottis, and also signs that air is getting in and out, which that just means that the epiglottis is shrinking back down to normal size. And so if you hear air leaks around the ET tube, that's the patient trying to breathe on their own. The patient can be discharged after 24 hours afebrile and stable. So once you get them extubated, if they stay stable for 24 hours, they don't spike any fevers, for the most part, then what we need to do in the hospital is over. We can switch their medications to oral, their antibiotics to oral, and they need to finish about a 7 to 10 day course of whatever antibiotic they were on. And lastly, contacts of patients with epiglottitis. And by contacts, I don't mean everyone they come into contact with. I mean people who share living quarters with them, possibly doctors. If you deal with a patient with epiglottitis, you may want to consider getting a one-time dose of rifampin. Rifampin reduces the risk of contracting epiglottitis. So this is going to be household family members, anybody like babysitter, if you know the baby sneezed on you or you were sharing cups or something like that, then rifampin is what you want to give these patients. But if it's just somebody like a friend on the football team or something like that, no need.